Okay. So who is going to take it? Start. Read, sister.
Initial resuscitation.
Sister, from there we will start. ಹೌದು. So welcome everyone. Today we are going to study about the initial resuscitation, pre-hospital care and emergency department care in a traumatic brain injury. Okay. It is very important that all of us know this. Whatever we are doing is based on book called as Yeoman's textbook of neurosurgery. Okay. And you can see this key concepts somebody should read. Read them.
A secondary insult, a physiologist
Derangement.
that worsens a primary brain injury should be distinguished from a secondary brain injury. The expected
Pathophysiologic sequelae of
pathophysiologic sequences of traumatic brain injury.
Okay, it's very simple. Primary injury is always followed by secondary injury. Okay, and any kind of physiologic derangement. What is physiologic derangement? What is the physiology of our body? Simple things you tell. Breathing, circulation. Okay, temperature maintenance. So airway, breathing, circulation. So all these things, if they are not in correct place, it is going to worsen the primary injury. Okay, and obviously if primary injury is worsened, then secondary injury also is going to increase. Okay, next line you read. Who is?
Traditionally thought of as an ordered sequence, recent studies suggest that primary survey components of airway, breathing and circulation may be performed in any order without significantly altering patient outcome.
Okay, so this mic is not working actually. All of you know airway, breathing and circulation. Okay, then next.
In practice, head CT is often part of the initial trauma evaluation. Head CT should be performed in all patients with moderate to severe TBI and in patients with mild TBI plus certain risk factors. Serum biomarkers are increasingly recognized as an adjunct to classify severity of TBI.
Okay, so CT scan is most important. After that, serum biomarkers. Okay.
The development
Read.
The development of multimodal monitoring and the exploration of factors that affect outcome thought the ongoing brain oxygen optimization in severe traumatic brain injury.
Brain oxygen optimization in severe traumatic brain injury. So severe we have read last time if you remember. Mild, moderate, severe, based on the Glasgow coma scale. Okay. So if GCS is less than 8, it is severe traumatic brain injury. Next.
Brains have
Read Baba.
has largely replaced Penicon and
Phenytoin.
other antipyretic drugs in the
Amma phenytoin, eptoin, amma. Read. What happened? Suddenly you did not have lunch.
Penicon and other antipyretic drugs and anti-epileptic drugs in post-traumatic seizure and prophylaxis because of the similar efficacy and
Amma, inga agalla. You have to learn to read properly. Okay, and you should make sure that you know what drugs you are giving. Okay, so phenytoin andre Aptoin. Okay. You have to always know what are the drugs, what are the names, and all these things. You have to. What is the dose of phenytoin? 100 mg TID. What is the loading dose? 800 mg in males, 600 mg in females. Levetiracetam. Keppra means levetiracetam. Okay. This Keppra here they have used the word no. That Keppra is levetiracetam. Okay. Very nice. Now next.
Although acute care surgery specialists are critical to the timely management of the patients with brain injury in the limited resource setting, transfer to a level I or
Level 1, level 2.
level 1 or 2 trauma center staffed with neurosurgeons remains vital to the long term care to TBI patients.
TBI means full form.
Traumatic brain.
Let her speak now. Okay. Next one. Read, Baba. Fast.
Pre-hospital management, rapid removal of the accident victim to a trauma care facility is critical to improve the chance of a survival.
Rapid removal of the accident victim to a trauma care facility. Okay. Now accident ಎಲ್ಲಿ ಆಗುತ್ತೆ? Example, ಪಟ ಕೊಡಿ. Discussion, this is to break the monotony. ಇಲ್ಲಿ ರೋಡ್ ಅಲ್ಲಿ ಆಗತ್ತೆ, ಮತ್ತೆ ಮನೆ ಒಳಗಡೆ ಆಗತ್ತೆ, ಇಂಡಸ್ಟ್ರಿ, ಬಾತ್ರೂಮ್ ಒಳಗಡೆ ಆಗ್ಬೋದು, ಟಾಯ್ಲೆಟ್ ಒಳಗಡೆ ಆಗ್ಬೋದು. ಓಕೆ, ಎಲ್ಲಿ ವೆರೆವರ್ ವಿ ಗೋ, ಸಮ್ ಪೀಪಲ್ ವುಡ್ ಹ್ಯಾವ್ ಗಾನ್ ಫಾರ್ ಟ್ರೆಕ್ಕಿಂಗ್ ಅಲ್ಲಿ ಹೋಗಿದ್ರೆ ಅದು ವೆರಿ ರಿಮೋಟ್ ಏರಿಯಾ. ಸೊ ಸ್ಪೋರ್ಟ್ಸ್ ಅಲ್ಲಿ, ಎಸ್ ಸ್ಪೋರ್ಟ್ಸ್ ಅಲ್ಲಿ ಇಫ್ ಇಟ್ ಇಸ್ ಇಂಟರ್ನ್ಯಾಷನಲ್ ಸ್ಪೋರ್ಟ್ ಲೈವ್ ಸ್ಟ್ರೀಮ್ ನಡೀತಾ ಇದೆ, ಸೊ ಇಮಿಡಿಯೇಟ್ಲಿ ಎಲ್ಲ ಡಾಕ್ಟರ್ಸ್ ನಿಂತ್ಕೊಂಡಿರ್ತಾರೆ ಆಲ್ರೆಡಿ, ದೇ ವಿಲ್ ಇಮಿಡಿಯೇಟ್ಲಿ ಟ್ರಾನ್ಸ್ಫರ್. ಬಟ್ ದೋಸ್ ಹೂ ಹ್ಯಾವ್ ಗೋನ್ ಫಾರ್ ಟ್ರೆಕ್ಕಿಂಗ್, ಮೊಬೈಲ್ ನೆಟ್ವರ್ಕ್ ಇರಲ್ಲ. ಇನ್ ಬಿಟ್ವೀನ್ ಕೇರಳ ಅಂಡ್ ತಮಿಳ್ನಾಡು ದೇರ್ ಇಸ್ ಅ ಪ್ಲೇಸ್ ಕಾಲ್ಡ್ ಅಗತ್ಯಮಲೈ. ಹ್ಯಾವ್ ಯು ಹರ್ಡ್? Their network only is not there for 40-50 kilometers. Network is not there. Okay, and trekking, 2.5. So all these things are very important. So for that, you should know how to take out accident victim. Very, very important. And do not start your mobile to record. Recently only I saw people are stuck inside the car, and other people are just stupid people. They are just taking videos. Nobody is helping the car to the toppled car to reverse the car. ಎಲ್ಲರೂ ವಿಡಿಯೋ ತಗೊಳ್ತಾ ಇದ್ದಾರೆ. ನೋಡ್ರಿ ಹಿಂಗೆ ಆಕ್ಸಿಡೆಂಟ್ ಆಗಿದೆ, ಹಂಗೆ ಆಕ್ಸಿಡೆಂಟ್ ಆಗಿದೆ, ಇದು ಟಾಟಾ ಕಂಪ್ನಿದು ಬಿಲ್ಡ್ ಎಷ್ಟು ಚೆನ್ನಾಗಿದೆ. ಬಟ್ ಟೇಕ್ ಔಟ್ ದ ಪೇಷಂಟ್ ಫಸ್ಟ್. ಕರೆಕ್ಟ್ ಅಲ್ವಾ? ಸೊ ದೀಸ್ ಆರ್ ದ ಥಿಂಗ್ಸ್ ವಿಚ್ ವಿ ಶುಡ್ ಸ್ಟಾಪ್. ಅಂಡ್ ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ಏನಾಗಿದೆ, ಇಷ್ಟು ರೆಗ್ಯುಲರ್ ಆಗಿ ಆಗ್ತಾ ಇದೆ ಆಕ್ಸಿಡೆಂಟ್ಸ್. ಎಷ್ಟು ರೆಗ್ಯುಲರ್ ಆಗಿ ನಾವು ಸ್ಕ್ರೀನ್ ಮೇಲೆ ನೋಡ್ತಾ ಇದ್ದೀವಿ, ಅದಕ್ಕೋಸ್ಕರ ನಾವು ಎಲ್ಲರೂ ಇನ್ಸೆನ್ಸಿಟಿವ್ ಆಗ್ಬಿಟ್ಟಿದೀವಿ. ಏನಾಗ್ಬಿಟ್ಟಿದೀವಿ? ಇನ್ಸೆನ್ಸಿಟಿವ್. ಹಾಸ್ಪಿಟಲ್ ಮುಂದೆನೆ ಡಿವೈಡರ್ ಬ್ರೇಕ್ ಮಾಡಿ ಅದು ಹೊಸ ಮಾಡಿದ್ದಾರೆ, ಅಲ್ಲಿ 10 ಜನ ಸತ್ತೋಗಿದ್ರು ಸೆನ್ಸಿಟಿವಿಟಿ ಬರ್ತಾ ಇಲ್ಲ, ಇನ್ಸೆನ್ಸಿಟಿವ್ ಆಗ್ಬಿಟ್ಟಿದ್ದಾರೆ. ಆಗ್ಲಿ ಸತ್ತೋಗ್ಲಿ, ಕಾರ್ ಸ್ಟಾಪ್ ಆಗತ್ತೆ, ಟ್ರಕ್ ಸ್ಟಾಪ್ ಆಗತ್ತಲ್ವಾ, ಸಡನ್ ಆಗಿ ಬ್ರೇಕ್ ಮಾಡ್ತಾರೆ, ಸಡನ್ ಆಗಿ ಸೌಂಡ್ ಬರುತ್ತೆ. ಬಟ್ ಇನ್ಸೆನ್ಸಿಟಿವ್, ದಿಸ್ ಈಸ್ ಇನ್ಸೆನ್ಸಿಟಿವಿಟಿ. ಓಕೆ, ಸೊ ಆಕ್ಸಿಡೆಂಟ್ ಆಗತ್ತೆ, ಆವಾಗ ಮೊಬೈಲ್ ಒಂದೇ ಒಂದು ಕೆಲ್ಸಕ್ಕೆ ತೆಗಿಬೇಕು, ಫಾರ್ ಕಾಲಿಂಗ್ ಆಂಬ್ಯುಲೆನ್ಸ್ ಅಂಡ್ ಹೆಲ್ಪ್. ಓಕೆ, ನೆಕ್ಸ್ಟ್ ರೀಡ್.
Guidelines for a pre-hospital management outlined by the Brain Trauma Foundation have been useful. In this respect, paramedical personnel must work with the police and the fire service to secure the scene and remove the patient safely.
Remove the patient safely without causing
injury either to the casualty or other personnel at the scene. The basic life support,
scoop and run. ಸ್ಕೂಪ್ ಎಲ್ಲಿ ಮಾಡ್ತೀವಿ ಅಮ್ಮ? ಸ್ಕೂಪ್ ಈ ಶಬ್ದ ಎಲ್ಲಿ ಯೂಸ್ ಮಾಡ್ತೀವಿ? ಐಸ್ ಕ್ರೀಮ್ ಅಂಗಡಿ ಒಳಗಡೆ 1 ಸ್ಕೂಪ್ ಐಸ್ ಕ್ರೀಮ್, 2 ಸ್ಕೂಪ್ ಐಸ್ ಕ್ರೀಮ್. This is not only just neurosurgery class, this is English class also, personality development class also. ಸ್ಕೂಪ್ ಯೂಸ್ ಮಾಡಿದ್ದೀರಾ ಮಾಡಿಲ್ಲ? ಈಗ ಗೊತ್ತಾಗ್ತಾ ಇದೆ ಅಲ್ವಾ? ಅದು ರೋಬೋಟ್ ತರ ಕೆಲಸ ಮಾಡಬಾರ್ದು. ನಿಮ್ದು ಮುಖ ತೋರಿಸಿ ಫಸ್ಟ್ ಟೈಮ್ ನೋಡ್ತಾ ಇದ್ದೀನಿ. ನ್ಯೂ ಜಾಯಿನ್ ಇಸ್ ನೋ? ವಾಟ್ ಈಸ್ ಯುವರ್ ನೇಮ್?
Ratna.
ರತ್ನಾ. ವಾಟ್ ಈಸ್ ಹರ್ ನೇಮ್?
Shobha.
ಎಲ್ಲಿಂದ ಬಂದಿದ್ದೀರಾ?
Maharashtra. Kantan.
हा महाराष्ट्र मध्ये कुठे?
Kantan Bogla.
हा
Kantan Bogla.
कुठे आहे रे बाबा हे?
Jat तालुका.
हा
Jat तालुका.
जत तालुका, जिल्हा सातारा, सांगली. ओके. हा
Bijirki.
हा
Bijirki.
ಎಲ್ಲಿ ಎಂಬ ಇದು? ಬಿಜಾಪುರ. ಅದು ಬಿಜ್ಜಿರ್ಗಿ ಪೆಟ್ರೋಲ್ ಪಂಪ್ ಇದೆ ಅಲ್ವಾ? ಓಕೆ ಸರಿ, ನೆಕ್ಸ್ಟ್.
Strategy meaning rapid evacuation and treatment at the skill trauma center may yield more favorable outcomes than the advanced life support stay and play strategy of aggressive pre-hospital management in the field, particularly in the penetrating.
ನೋಡಿ, ಯಾರಿಗೆ ಬೇಸಿಕ್ ಲೈಫ್ ಸಪೋರ್ಟ್ ಗೊತ್ತಾಗ್ತಾ ಇದ್ರೆ ದೇ ಡೋಂಟ್ ಹ್ಯಾವ್ ಟು ವೇಸ್ಟ್ ಟೈಮ್. ಅವರು ಏನ್ ಮಾಡಬೇಕು? ಸ್ಕೂಪ್ ಅಂಡ್ ರನ್. ಪೇಷಂಟ್ ಇಟ್ಬಿಟ್ಟು ಇಮಿಡಿಯೇಟ್ ಆಗಿ ಯು ಹ್ಯಾವ್ ಟು ಮೂವ್ ಸೇಫ್ಲಿ. ಇಫ್ ಯು ನೋ ಅಡ್ವಾನ್ಸ್ ಲೈಫ್ ಸಪೋರ್ಟ್, ಸ್ಟೇ, ಪ್ಲೇ, ಸ್ಟೆಬಿಲೈಸ್ ABC and then you take the patient. Okay? ಓದ್ರಿ.
Trauma and the
ಪರ್ಟಿಕ್ಯುಲರ್ಲಿ ಇನ್ ಪೆನೆಟ್ರೇಟಿಂಗ್ ಟ್ರಾಮಾ. ಪೆನೆಟ್ರೇಟಿಂಗ್ ಟ್ರಾಮಾ ಹೈವೇಸ್ ಅಲ್ಲಿ ಏನಾಗತ್ತೆ, ಹೆಂಗಾಗತ್ತೆ? ರಾಡ್ಸ್, ಸ್ಟೀಲ್ ರಾಡ್ಸ್ ಅದೆಲ್ಲ ಗ್ಲಾಸ್ ಪೀಸಸ್ ಇದೆಲ್ಲ ಇರುತ್ತೆ. ಓಕೆ, ನೆಕ್ಸ್ಟ್.
perhaps in the blunt severe head injury.
ಬ್ರಾಂಚಸ್ ಆಫ್ ದ ಟ್ರೀಸ್, ತುಂಬಾ ಬೇರೆ ಬೇರೆ ತರ ಇದೆ ಪೆನೆಟ್ರೇಟಿಂಗ್ ಇಂಜುರಿ ಕೂಡ. ಓಕೆ, ಓದ್ರಿ ನೆಕ್ಸ್ಟ್.
Although expertise in safely extricating patients is
ಎಕ್ಸ್ಟ್ರಿಕೇಟಿಂಗ್ ಪೇಷಂಟ್ಸ್
patients is crucial.
ಕ್ರೂಷಿಯಲ್.
There is no considerable evidence that the experience of rescues, medical training and the
rescuers,
medical training and the
timeliness of transport
to an appropriate hospital also influence patient's outcomes.
ಓಕೆ, ಸೊ ಪೇಷಂಟ್ ಔಟ್ಕಮ್ ಡಾಕ್ಟರ್ ಮೇಲೆ ಡಿಪೆಂಡ್ ಇಲ್ಲ. ಡಾಕ್ಟರ್ ಹೆಸರು ಬಂತ ಇದರಲ್ಲಿ. ಹೂ ಆರ್ ದ ಒನ್ಸ್? ಫಸ್ಟ್ ಏನ್ ಹೆಸರು ಇದೆ? ರೆಸ್ಕ್ಯೂವರ್. ರೆಸ್ಕ್ಯೂವರ್ ಅಂದ್ರೆ ಯಾರು? ಎವ್ರಿ ಒನ್. ಸೊ ದಟ್ ಈಸ್ ವೈ ಇಟ್ ಈಸ್ ವೆರಿ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್ ದಟ್ ಆಲ್ ದ ಸಿಟಿಜನ್ಸ್ ಶುಡ್ ಲರ್ನ್ basic life support. We can think about conducting BLS for citizens. One workshop we can conduct, 30 slots, same we can organize. Madidira? We will arrange. Okay. Next, medical training. Medical training andre that also everybody's medical training is important. Next, ಟೈಮ್ಲಿನೆಸ್ ಆಫ್ ಟ್ರಾನ್ಸ್ಪೋರ್ಟ್. ಟ್ರಾನ್ಸ್ಪೋರ್ಟ್ ಟೈಮ್ಲಿನೆಸ್ ಅಂದ್ರೆ ಯಾರು? ಆಂಬ್ಯುಲೆನ್ಸ್ ಆರ್ ಎನಿ ಪರ್ಸನ್ ಹೂ ಇಸ್ ನೋಯಿಂಗ್ ಡ್ರೈವಿಂಗ್. ಓಕೆ, ಆಟೋ ರಿಕ್ಷಾ ಡ್ರೈವರ್, ಕಾರ್ ಡ್ರೈವರ್, ಟ್ರಕ್ ಡ್ರೈವರ್, ಎನಿಬಡಿ. ಆರ್ ಇಫ್ ಇಟ್ ಇಸ್ ಅ ಡೆವಲಪ್ಡ್ ಕಂಟ್ರಿ, ಹೆಲಿಕಾಪ್ಟರ್ ಆಲ್ಸೋ. ದೆನ್ ಲಾಸ್ಟ್ ಅಲ್ಲಿ ಏನಿದೆ? ಅಪ್ರೋಪ್ರಿಯೇಟ್ ಹಾಸ್ಪಿಟಲ್, ಕರೆಕ್ಟ್ ಹಾಸ್ಪಿಟಲ್ ಹೋಗ್ಬೇಕು. ನೆಕ್ಸ್ಟ್, ಓಕೆ, ಸೊ ಆಲ್ ದೀಸ್ ಥಿಂಗ್ಸ್ ವಿಲ್ ಇನ್ಫ್ಲೂಯೆನ್ಸ್ ಪೇಷಂಟ್ ಔಟ್ಕಮ್ಸ್. ಇವಾಗ ತನಕ ಡಾಕ್ಟರ್ ಹೆಸರು ಬಂದಿಲ್ಲ. ಓಕೆ, ನೆಕ್ಸ್ಟ್. ಓವರ್ ನೋ, ಯುವರ್ ಪ್ಯಾರಾಗ್ರಾಫ್ ಇಸ್ ಓವರ್. ನೆಕ್ಸ್ಟ್ ಯಾರು ಓದ್ತಾರೆ? ಟೇಕ್ ಬಾಬಾ.
The importance of pre-hospital service has been underlined by the prospective study comparing the overall mortality rate of severe and moderate TBI patients in two different environments, New Delhi, India and Charlottesville, Virginia. The overall mortality rate was
not Charlotte, it is Charlottesville.
Virginia. The overall mortality rate was 11% in New Delhi versus 7.2% in
Charlottesville.
The mortality rates for victims with
ನ್ಯೂ ಡೆಲ್ಲಿಯಲ್ಲಿ ಏನಾಗಿದೆ ಜಾಸ್ತಿ ಇದೆ. ಯಾಕೆ? ಪೊಲ್ಯೂಷನ್ ಇಲ್ಲ. ವಾಟ್ ಆರ್ ವಿ ಟಾಕಿಂಗ್ ಅಬೌಟ್? ಯು ಸಿ ಪ್ರೀ ಹಾಸ್ಪಿಟಲ್ ಸರ್ವಿಸ್, ಹಾಸ್ಪಿಟಲ್ ಬರಕ್ ಮುಂಚೆ ವಾಟ್ ಆರ್ ದ ಸರ್ವಿಸಸ್? ಓಕೆ, ನೆಕ್ಸ್ಟ್.
the mortality rate for victims with severe injuries, GCS motor score of 1 to 4, and those with mild injuries, GCS motor score of 6, were similar at both centers. The patients with moderate injuries, GCS motor score of 5.
See, this is not the complete GCS. This is a partial GCS. This is only motor score which we are talking about. What is the maximum motor score? 6. What is the minimum motor score? Okay. So if motor score is 4, automatically it is severe. Okay. Then next.
Had a mortality rate of 12.5% in New Delhi compared with the 4.8% in Charlottesville.
You are also new.
Yeah, sir.
What is your name?
Vishwanath, sir.
Yellinda.
Vijaypur local, sir.
Okay.
This dramatic difference is attributed to the differences in pre-hospital emergency services. In New Delhi, 2.7% of victims received first aid administered by paramedical personnel or police before arriving at the hospital, whereas
Charlottesville.
paramedics attend to 84.3% of victims and transport them by ambulance.
ಅರ್ಥ ಆಯ್ತಾ? You got the idea?
Yes, sir.
If 100 accidents have happened, only 3 people received first aid in New Delhi. And New Delhi is what? It is not Vijaypura. New Delhi is what? Capital of India. ಇಲ್ಲಿ ಎಷ್ಟು ಪರ್ಸೆಂಟ್ ಆಗಿರ್ಬೋದು? ಫಸ್ಟ್ ಏಡ್ ಸಿಗತ್ತಾ ಇಲ್ಲಿ? ಸಿಗ್ಬೇಕೋ ಸಿಗ್ಬಾರ್ದು? ಮತ್ತೆ ಯಾರು ಮಾಡ್ತಾರೆ ಅದು? ಅದನ್ನು ಬಸವನಗುಡಿ ಆದ್ಮೇಲೆ ಹೇಳ್ಬೇಕಾ ಎಲ್ಲರಿಗೆ? ನೀವು ಹೇಳ್ತೀರಾ? ನಾವು ಎಲ್ಲರೂ ಹೇಳ್ಬೇಕಾಗತ್ತೆ. We have to tell people how to do first aid. You are all, whoever are here, what you should do, you should take responsibility of at least 5 families and try to go and teach them what is first aid. First aid ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ ಹೇಳಿ ನನಗೆ ಬ್ರದರ್. Brother will tell why did I join. ಹೇಳಿ ಸಿಸ್ಟರ್. ಫಸ್ಟ್ ಏಡ್ ಬ್ರದರ್ ನೀವು ಹೇಳ್ತೀರಾ ಹೇಳಲ್ಲ? ನಿಮ್ದು ಹೆಸರೇನು? ಎಲ್ಲಿಂದ? ನ್ಯೂ ಜಾಯಿನ್ ಎಲ್ಲಿಂದ?
ಆಯುಷ್ ಹಾಸ್ಪಿಟಲ್
ವಿಜಯಪುರ. ನೀವು ಹೇಳ್ತೀರಾ ಫಸ್ಟ್ ಏಡ್ ಅಲ್ಲಿ ಏನೇನ್ ಮಾಡ್ಬೋದು ಅಂತ? ಹೇಳ್ತೀರಾ ಹೇಳಲ್ಲ?
ಎಮರ್ಜೆನ್ಸಿ ಏನಾಗುತ್ತೆ?
ಫಸ್ಟ್ ಏಡ್ ಅಲ್ಲಿ ಏನೇನ್ ಇರುತ್ತೆ, ಏನೇನ್ ಮಾಡ್ಬೋದು? ಫಸ್ಟ್ ಏಡ್ ನಾನು BLS ಬೇಸಿಕ್ ಲೈಫ್ ಸಪೋರ್ಟ್ ಹೇಳ್ತಾ ಇಲ್ಲ. ಫಸ್ಟ್ ಏಡ್
ಡ್ರೆಸ್ಸಿಂಗ್ ಮಾಡೋದು.
ಡ್ರೆಸ್ಸಿಂಗ್ ಯಾಕೆ ಮಾಡಬೇಕು?
ಬ್ಲೀಡಿಂಗ್ ಸ್ಟಾಪ್ ಆಗುತ್ತೆ.
ವಾಟ್ ವಿ ಹ್ಯಾವ್ ಟು ಡೂ? You have to try to stop bleeding. What is the most easiest thing to stop bleeding? Compression. Second, elevation. And whatever is the bleeder, there you can put gauze and you can tie. Tamponade effect now continuous kodbodu. Okay. So we will see as we go on. We will try to do that also. First aid. One first aid workshop, one BLS workshop, ಆ ಥರ ನಾವು ಸ್ಟಾರ್ಟ್ ಮಾಡೋದು ಫಾರ್ ಜನರಲ್ ಪಬ್ಲಿಕ್. ದ ಡಿಫ್ರೆನ್ಸಸ್ ಇನ್ ಟ್ರಾನ್ಸ್ಪೋರ್ಟೇಷನ್ ವೇರ್ ಆಲ್ಸೋ. ಯಾರು ಓದ್ತಾರಪ್ಪ? ಯಾರ ಕೈ ಇತ್ತು? ಅನಿತಾ ಸಿಸ್ಟರ್ ಓದ್ರಿ ಇದ್ರಾದ್ಮೇಲೆ.
The differences in transportation were also reflect in the percentage of patients admitted to the hospital within 1 hour of being injured. 6.9% in New Delhi compared with 50.2% in the
numbers don't lie. Numbers don't lie. I think there is a song, no, by which, who is that singer? Brazilian singer? No, Colombian singer. Shakira, no? Shakira, there is a song called Hips Don't Lie. Shakira, hips don't lie, but your numbers don't lie. Okay, you can see here 6.9, only 7 people out of 100 have reached to hospital within 1 hour. And 1 hour is what? Golden hour. What it is? Golden hour. Whereas Charlottesville, 50 people have reached. One thing is, their bleeding was stopped in Charlottesville. In out of 100, 84 people were able to get bleeding stop. Bleeding stop ಆಗೋದು ಯಾಕೆ ಇಂಪಾರ್ಟೆಂಟ್ ಇದೆ? ಬ್ಲಡ್ ಲಾಸ್ ಆಗ್ಬಿಟ್ರೆ ಏನಾಗುತ್ತೆ? ಹೈಪೋವಾಲಮಿಕ್ ಶಾಕ್ ಆಗುತ್ತೆ. ಬಿ ಪಿ ಕಡಿಮೆ ಆಗಿದ್ರೆ ಸೆರೆಬ್ರಲ್ ಪರ್ಫ್ಯೂಷನ್ ಪ್ರೆಷರ್ ಕಡಿಮೆ ಆಗುತ್ತೆ. ಸೆರೆಬ್ರಲ್ ಪರ್ಫ್ಯೂಷನ್ ಪ್ರೆಷರ್ ಕಡಿಮೆ ಆಗಿಬಿಟ್ರೆ ಇಸ್ಕೆಮಿಯಾ ಚಾನ್ಸಸ್ ಜಾಸ್ತಿ ಆಗ್ಬಿಡುತ್ತೆ. ವೆರಿ ಸಿಂಪಲ್. And that is why they are able to show by very simple. They have done one study in New Delhi, one study in US. They have picked up 2 cities and they have shown that what is the level of India. And it's very shameful, honestly speaking, because New Delhi is the capital of our country. And then it opens up very big discussions actually. Yake? Because it means that the vehicles were getting stuck in traffic. So it means that our transport system is not good. Our infrastructure in terms of road, buildings, hospital, adu ella, it's not at correct place. Okay, next. Odri. Amma odi ma.
In religions,
In the region amma.
regions where our transport is a
Air transport amma. Helicopter.
air transport is a feasible mean of decreasing transport time to the trauma center. Reduction in predicted mortality rates as high as 52% have been reported.
So the means if you can transport the patient by air, then it is further faster and the mortality rate will become half. 52% means half ಆಗ್ಬಿಡುತ್ತೆ. ಅಂದ್ರೆ ನೀವು ಬಿಜಾಪುರಲ್ಲಿ ಆಕ್ಸಿಡೆಂಟ್ ಆಗ್ಬಿಟ್ರೆ does not mean that you ask for helicopter. Whichever is nearest hospital ಅಲ್ಲಿ ರೀಚ್ ಆಗಬೇಕು ಅಷ್ಟೇ. ನೋ ನಾನು ಓದಿದ್ದೀನಿ ಹೆಲಿಕಾಪ್ಟರ್ ಏರ್ ಟ್ರಾನ್ಸ್ಫರ್ ಮಾಡಿದ್ರೆ ಪೇಷಂಟ್ ಬೇಗ ವಾಸಿ ಆಗ್ತಾರೆ ಅಂತ ಹಂಗ್ ಕೇಳಬಾರ್ದು. ವಾಟ್ ಎವರ್ ಇಸ್ ದ ನಿಯರ್ ಬೈ ಯು ಹ್ಯಾವ್ ಟು ಯೂಸ್ ಇಟ್. ಓಕೆ, ನೆಕ್ಸ್ಟ್ ಓದಿ ಬ್ರದರ್. ನೆಕ್ಸ್ಟ್ ಪ್ಯಾರಾಗ್ರಾಫ್ ಯು ಟೇಕ್.
The introduction of helicopter emergency in medical services has revolutionized traumatic care and has been shown to improve survival outcomes. Proper identification of a critical injured patient who need rapid transport is important for optimal use of this expensive mode of transport. The concept of physician staffed helicopter emergency medical services has introduced to provide a more definitive care to blood trauma victims without prolonging the on-scene time. Initial studies
ಸೀನಪ್ಪ ಮೂವಿಯಲ್ಲಿ ಸೀನ್ ಇರತ್ತಲ್ವಾ, ಅದೇ ಸೀನು, ಬೇರೆ ಯಾವುದು ಸೀನ್ ಇಲ್ಲ. ಓದು.
Initial studies showed up to a 35% decrease in mortality rate among the patient treated by a nurse physician teams. Recent studies, however, have not shown any benefit in outcomes compared with the non-physician staffed in helicopter emergency medical services.
ಮತ್ತೆ ಆಯ್ತಾ? So initial studies have shown that if there is a nurse physician team, what will happen? 35% decrease. Now at this moment in our ambulances, do we have nurse and physician? Nurse is there. Physician?
Sometimes.
Okay, fine. Odri. ಓದಪ್ಪ, ಏನಾಯ್ತು? ಮೌನ ವ್ರತ ಧಾರಣ ಮಾಡಿದೀಯಾ?
Recent studies, however, have not shown any.
ಒಂದು ನಿಮಿಷ. Okay. Odapa.
All patients with GCS score of 8 less or must be
8 or less.
must be intubated and given controlled ventilation with continuous monitoring of oxygenation by pulse oximetry. Preventing hypoxemia and hypercapnia is crucial step in pre-hospital management.
Okay, 1 second. So GCS is less than 8. First of all, you should know how to calculate GCS. Now it is very simple. For you, I will teach you ulta. If patient is not opening eyes, if patient is not speaking, and if patient is not moving, what is the GCS? 3. Okay. If patient is not opening eyes, not speaking, and doing like this, what it is? 4. If same patient's eyes are closed, not speaking, and doing like this, 5. If patient is not able to localize and moving but here there, not able to reach to the pain point, 6. Patient is not speaking, not opening eyes and localizing, 7. So if patient is not opening eyes and not speaking till patient is becoming conscious or obeying the commands also, obeying commands will not happen. If obeying commands is there, the eye and the verbal response also will improve. Okay. So these are the things. So if patient is localizing but not obeying, it means that it is potentially GCS less than 8. That is the whole thing. Okay. So in that scenario, you need to have controlled ventilation. And for that, there should be someone who is able to intubate the patient, preferably intubate the patient in ambulance itself. Okay, that kind of awareness, if it is there, it will be great. But there is a risk, one more risk. How to intubate the patient? If it is an injury patient, how to intubate? Without moving the spine. We have to, with a jaw thrust, you have to intubate. You can't intubate by extension. Okay, chalo, next. Odappa.
Treatment is similar in head injury patient with significant deterioration of level of
Deterioration. Significant
deterioration of level of consciousness, seizures, respiratory distress, and severe facial and thoraco-abdominal injuries.
Okay, wait. Now you have seen all the patients, almost everyone comes with facial injury. Why? Because they are not wearing helmet. Okay, face injury agbitre ಏನಾಗುತ್ತೆ? What is the risk? Secretions will go into the mouth. Airway may get obstructed. That is the whole idea, and that is why it is dangerous. And that is why we have to learn to manage that correctly and make the patient reach place properly. Thoraco-abdominal injury, ICD placement, that also people should know. Okay, next one. What happened?
The priority for emergency medical services is to immobilize the spine and achieve a safe airway for use of rapid sequence intubation.
So this also you remember. Okay, and now all these questions you have to ask to your intensivist. What is rapid sequence intubation? And I request all of you, whoever are working, how many of you are working in ICU? Whoever are working, do you know how to intubate? Have you intubated? Have you intubated? Yes or no? Nija ಹೇಳಬೇಕು. Now, your job is to learn intubation. First on mannequin. You have no mannequin. You have mannequin, you learn. Then gain confidence of your intensivist and ask. Because sometimes if it is needed and if nobody is able to intubate, if you are there, you will be able to help them out. Okay? Sarina? Next, where are the duty doctors, man? There is no duty doctors here. They know all everything, all neurosurgery they know. Then why I am needed here? Huh? Okay, anyhow. Next.
A study at Harborview Medical Center showed a decreases in mortality among traumatic brain injury patient after early pre-hospital intubation. Although the rate of severe hypercapnia was 18% patient with severe hypercapnia and higher injury severity of scores and were more likely hypotensive, hypoxic and acidotic. The San Diego paramedics
RSI, rapid sequence intubation.
trial documented an increase in mortality after paramedic rapid sequence intubation with hyperventilation and aspiration pneumonia identified as a major risk factors. Adequate training, regular experience and close monitoring of a limited group of providers helps to maximize their exposure to and experience with rapid sequence of intubation.
What I spoke is written there. Correct? Adequate training, then regular experience, then close monitoring. So somebody has to observe you, somebody has to monitor you for your whatever techniques you are developing. Okay, next. Who is going to read? Brother. Odoma bega.
Guidelines for pre-hospital management of traumatic brain injury, ETCO2, N-tidal carbon dioxide, GCS Glasgow coma scale, TaCO2 arterial partial pressure of carbon dioxide, SpO2 arterial oxyhemoglobin saturation.
Now, in our ICU, are we getting ETCO2 values? Find out with intensivist. Okay, find out with intensivist whether we are getting ETCO2 or not. Okay, next.
Assessment oxygenation and blood pressure. Monitor oxygen saturation and blood pressure continuously. Avoid hypoxemia less than 90% due to saturation and hypotension less than 90 mmHg systolic blood pressure. Assessment GCS score used as a reliable indicator of severity of traumatic brain injury and also for prognosis. Obtain after securing airway, breathing and circulation. Obtain before administering sedatives or paralytics. Obtain using trained personnel by interacting with the patient. Assessment, pupil examination, assess in the field for use in diagnosis and prognosis, note evidence of orbital trauma, assess after resuscitation and stabilization, record bilateral pupillary size and reflex, treatment, airway ventilation and oxygenation, establish an airway with supplemental oxygen in patients who have severe brain injury, inability to maintain an airway or hypoxemia. Avoid hypoxemia.
Give it to sister. So you saw most important is airway. If you secure airway, oxygenation will happen properly. Next.
Monitor blood pressure, oxygenation and ETCO2 while implementing endotracheal intubation protocols. Confirm the position of the endotracheal tube by auscultation and ETCO2 determination. Avoid hyperventilation unless patient shows evidence of cerebral herniation.
Okay, if there is brain edema, if we hyperventilate the patient, it is helpful. Hyperventilation for a short duration will help the patient to achieve relaxation in the brain edema. Okay, but not for a long time. If we do for a long time, chances of ischemia increase. Okay, next.
In ground transportation in urban environment, routine use of paralytics is not recommended for intubation of adult patients who are spontaneously breathing and maintaining saturation above 90%.
So you always remember, saturation will give you an indicator whether we need to do something or not. Okay. Next.
Fourth one, treatment fluid resuscitation. Treat hypertensive patient with the isotonic fluids.
Okay, who is going to take a class from all of you? Who is going to take a class on fluids? I want any duty doctor or somebody to take one class on fluids. They have to prepare proper slides, and I don't like if duty doctors are not there. This is not correct.
I have posted a.
No, I am not blaming you. It has to, people have to come and join. Knowledge is very, very important for safe management of patient. We cannot just try to finish the hours and go and not learn anything. It's not correct. Okay, any one of you wants to join in that fluid management class? You will do? You will do? Oh. So you people decide what you will present. Okay? Read, sister.
Treatment and cerebral herniation. Avoid mild or prophylactic ventilation. Assess patient frequently for clinical signs of cerebral herniation, which include a dilated and non-reactive
Okay.
pupils.
So pupillary asymmetry. One pupil is dilated, one pupil is not dilated. Okay, pupillary asymmetry. The side which is dilated might have which herniation? Uncal herniation. Okay. Patient is not breathing properly. Apnea is happening. Which herniation? Tonsillar herniation. Okay, like that. Okay. Next.
Asymmetrical pupils, extensor posturing, no responses, or progressive neurological deterioration, decrease in GCS score by more than 2 points from prior best score. In patients who are normoventilated, well oxygenated, and normotensive hyperventilation can be used as temporizing measures to keep ETCO2 between 30 and 35 mm of Hg.
You remember this also. Okay.
If used, administrator hyperventilation at 20 breaths per minute in an adult, 25 breaths per minute in child, and 30 breaths per minute per infant.
What is the normal breathing rate?
16 to 24.
15 to 20 it is, or some books mention 12 to 15. Okay. So we are hyperventilating for adults 20. Okay. In children 25 and in infants 30. Okay. Chalo, give it off to other one. Okay, I will read one paragraph for a change. It is difficult to attribute improved outcomes in patients treated in pre-hospital settings to a specific intervention. However, prevention of hypoxia, hypotension appears to be vital. The incidence of hypoxia or hypotension on arrival at hospital has been shown to decrease from 30 to 12% by simple improvements in the pre-hospital airway management, including an increased use of intubation and mechanical ventilation. So that is why when patient is entering the ambulance itself, ventilation should be happening. That is why ventilator assisted ambulance and physician and nurse assisted. That much, if a well knowledgeable and well experienced pre-hospital staff is there, then automatically it is going to improve the chances of survival. Hypoxia and hypotension will be prevented. The incidence of hypoxia, hypotension on arrival from 30 to 12% it will decrease. Then patients with hypotension after severe traumatic brain injury have twice mortality rate of normotensin. So that is where comes that Elli our sister. Yen hesaru our sister? Anita sister. That is where is the importance of first aid. If you people have car or bike, do you know where is your first aid kit? Bike alli irutte first aid kit. Idiya bisakbitya? Ide. Just pray that you should never get to use it. Okay. Then therefore aggressive resuscitation of intravenous fluid is recommended in current guidelines for management of patients with severe traumatic brain injury. Treatment of increased intracranial pressure with patients with traumatic brain injury is also likely to improve outcomes. So what if somebody identifies the raised intracranial pressure inside the ambulance itself and gives 1 dose of mannitol. Will it be good? It will be good, no? What if they intubate and start hyperventilating the patient? Will it be good? Yes, it will be good. Okay. So these are very, very interesting thought processes which we have to develop. A double-blind randomized control trial has shown the efficacy of hypertonic saline as a resuscitation fluid in traumatic brain injury patients in a pre-hospital setting without affecting long-term neurological outcome. So it is efficacious. Hypertonic saline andre yavdu? I will tell you, in neurosurgery we use only NS. What we use? No DNS. Only NS. And one is normal saline, another one is 3% normal. So 3% normal saline is nothing but hypertonic saline. Okay, next. Audrey, yaar ottara?
Adequate resource must include paramedics or physician in the emergency response group who are capable of intubating patients in the pre-hospital settings. When a GCS score is determined in the pre-hospital settings, it can be useful as a comparison with the score in the emergency department. Winkler and co-workers demonstrated that those whose GCS score did not improve between the pre-hospital and initial hospital evaluations had poor outcomes.
Okay. So you understood, no? If you are intervening and patient is showing good response, then chances of patient outcomes are good. Okay. But if the patient is not improving or deteriorating, then patient is going to go down further. Okay. Next one.
Ongoing efforts to identify pre-hospital intervention to reduce morbidity and mortality of brain injured patients have thus far
Yielded
controversial results following the crash to study of 2010, which demonstrated a survival benefit for trauma patient at risk
Okay,
for
who has received patients in emergency? Okay, what do you ask for a trauma patient? What do you ask? No, do you ask anything was given in the ambulance or anything? Do they give anything in ambulance? Do they intubate the patient in ambulance? Do you receive such kind of patient? Do you have any data about pre-hospital services? I think you should develop one assessment sheet for pre-hospital intervention. We can see what kind of patients are coming and what kind of treatment is being given before reaching the hospital. Okay? Will you do that? Will you bring back to me?
Yes.
That fellow had given one work, they disappeared. I had told for trauma assessment sheet. He said, but he did not. You tell. Okay? And this pre-hospital thing, you make one sheet. Okay? Next. Odrima.
trauma patient at risk for hemorrhagic shock who received tranexamic acid. Tranexamic acid. The crash trial aimed to extend this pending to TBI patient. The crash 3 study concluded that tax within 3 hours of injury was
TXA man, TXA.
TXA.
Tax Nirmala Sitharaman ಕೊಡ್ತಾರೆ, TXA ನಾವು ಕೊಡ್ತೀವಿ.
TXA within 3 hours of injury was safe and reduced head injury related death. However, a more recent study extending TXA to out of hospital treatment
within 2 hours did not identify any significant improvement in a 6-month neurological outcome. Further studies will be required to identify which subset of TBI patient may benefit from the implementation of TXA.
Tranexamic acid.
Acid.
Okay, so it is not completely pause, injection pause. Okay, chalo, next one. Amma read properly.
General Trauma Resuscitation and Trauma Team. The American College of Surgeons Committee on Trauma has outlined guidelines regarding responsibility of the trauma response team. The
ಇದು
composition
ಉಪಯೋಗ ಆಗ್ತಾ ಇದೆಯಾ ಇಲ್ಲ ನಿಜಾನಾ ಅಥವಾ ಸುಮ್ಮನೆನಾ ಅಥವಾ ಎ ಸಿ ಚೆನ್ನಾಗಿದೆ ಇಲ್ಲಿ ರೂಮ್ ಸ್ವಲ್ಪ ದೊಡ್ಡದಿದೆ ತಲೆಗೆ ಯಾರು ಪೇಷಂಟ್ ರಿಲೇಟಿವ್ ಕೇಳಲ್ಲ 1 ಅವರ್ ಆ ತರ ಇದೆ ಅಥವಾ ಯು ಆರ್ ಗೆಟಿಂಗ್ ಸಮ್ ನಾಲೆಜ್ ಯು ಆರ್ ಗೆಟಿಂಗ್ ನಾಲೆಜ್ ಓಕೆ ಫೈನ್
The composition and organization of the trauma response team vary with available resources. The volume of trauma cases treated at each medical center and local government guidelines. The goal of the group is to receive patients in emergency department, treat the primary injuries and prevent additional injury. A center with few trauma cases may assess the resuscitate patients in general code room, whereas larger centers may use a
designated
trauma bed within the emergency department. Immediate access to a ventilator, operative instruments, unmatched O-negative packed red blood cells and plain radiographs is necessary. Prompt available of a CT scanner, preferably within an emergency department, is essential.
Okay, so you are seeing what and all is required: a ventilator, good ventilator, operative instruments, unmatched O negative. Do we have unmatched O negative? We store blood or not? And plain radiographs we have. CT scan we have. Okay, and preferably it has to be within this emergency department. Okay, these are the things, step by step guide now. Okay, next we will read. Odama.
Trauma center, particularly level 1 center, play in the important role in the management of the head injured patient in a multi-institutional.
Okay, for everyone. See, what happens is all of you are slightly scared to read. Matte, what you feel is, I will tell you, all of you are having inferiority complex. ನಿಮಗೆ ಏನು ಅನಿಸ್ತಾ ಇರುತ್ತೆ, ನನಗೆ ಗೊತ್ತಿಲ್ಲಪ್ಪ, ನಾನು ಏನೋ ಬುರ್ಬುರ್ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಮುಗಿಸ್ಬಿಡ್ತೀನಿ ಅಂತ. ಓಕೆ, ಡೋಂಟ್ ಡೂ ದಟ್. ಟ್ರೈ ಟು ರೀಡ್ ದ ವರ್ಡ್. ಓಕೆ, ವಾಟ್ ಈಸ್ ರಿಟನ್ ದೇರ್? INSTI, insti, TUTIONAL, tuitional, institutional ಅಂತ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡಿ. Just like that Parthav is there, no, small baby. Like that you try. In last 2 months he was not able to read anything, but now he will keep on hange ನಾನು ಹೇಳಿದೆ ಅಲ್ವಾ, ಹಂಗೆ ಮಾಡಕ್ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತಾನೆ, and that is how he will be able to read. So like that, same like him, we also can do the same thing. Okay, what he has done. Okay, chalo, continue.
Prospective study that involved the examination of cost of
Costs
and outcomes of care received by the more than 5,000 adult trauma patient 18 to 84 years of the age treated at 69 hospital located in the 12 states, conclude that the overall risk for the death in the significantly lower than care is provided at the trauma center rather than at non-trauma center. Severely injured patient with an injured
Injury severity score.
Severity
Sister,
score.
did you people put all these scores in the emergency? ಗ್ಲಾಸ್ಗೋ ಕೋಮಾ ಸ್ಕೇಲ್ ಅದು ನಾನು ಅಲ್ಗೋರಿದಮ್ ಹಾಕಕ್ ಹೇಳಿದೆ, ಅದು ಹಾಕಿದ್ರ? ಹಾಕಿ ಸ್ಟಾರ್ಟ್ ಮಾಡಿ, ಅದು ಹಾಕಿ, ಇದನ್ನು ಹಾಕಿ. ನಾರ್ಮಲ್ ಸ್ಕೋರ್ ಎಷ್ಟಿರುತ್ತೆ, ಹೆಂಗೆ ಮಾಡಬೇಕು ಅದೆಲ್ಲ ಹಾಕಬೇಕು. GCS ಇಂಜುರಿ ಸಿವಿರಿಟಿ ಸ್ಕೋರ್. ಓಕೆ, ನೆಕ್ಸ್ಟ್ ಅಮ್ಮ ಓದಿ.
Score higher than 15 treated in ACLS level in trauma. ACS level in trauma.
Level 1.
Level 1 trauma center have a considerably more favorable survival outcome than those treated in the ACS level 2nd center.
Level 2 centers. Okay, next up. Who is going to read? I am going to pause with this paragraph. Okay, this is the last paragraph we are going to read. Okay. Sister, you only.
The trauma population can have a higher incidence of
Blood-borne infections
compared with the general emergency department population.
Tardif
And
colleagues
studied the patients who died from trauma in New York City. Overall, 7.2% were human
HIV positive human immunodeficiency virus, HIV. Okay. So out of 100 patients, 7 patients were HIV positive. You have any data of emergency? Our emergency, how many patients come and how many of them were? You have any data? Can you draw out the data? See, sister, reading all these things will be fun only if we implement that here and see what is going on here. It will be fun. And it's not necessary that only Teresa sister and Nagavani sister only have to do. You can delegate all these works to these sisters, make an Excel sheet, who are the patients who came, trauma patients, from January 2024 to December 2024. In 1 year, how many patients came? You can match with the investigations which are done, HIV, HBsAg. And we have our own hospitals, 1 year data. Will you do that? Yes. Now, from now onwards, whatever we read will be correlated with JSS. And we will have the 1 slide or 2 slides from all of you. What is going on in JSS? Are we matching it? Okay, Serena, next.
Okay. And associated tested all patients visiting an inner city emergency department in
Baltimore.
Found that 24% were infected with at least one of the following: HIV,
24% mean every fourth patient. Every fourth patient is either HIV, hepatitis B, hepatitis C.
Virus hepatitis
Okay,
C.
it's not a joke.
Almost all the patients HBsAg positive.
See, if you are getting weekly 2-3 patients, okay, so in a year how much it will be? 150, 160. And these are not good viruses. Hepatitis B and C are not good viruses. Okay,
Because
you have to
of,
be very, very careful.
because of the increased risk in participants in the trauma by must strictly follow universal.
So that is why don't consider 24%, don't consider 7%, don't consider 10.8 and all. What you will consider? Every patient is positive. Then only you will be able to do justice to yourself. Forget about anybody else. What is there? Read about
Precautions. This include a
fluid impervious gown.
Mask, eye shield, head covering, and gloves.
Now you tell me how many of you touch the patients without gloves? Everyone, correct? emergency, it is compulsory to have gown, to have mask, to have eye shield, and to have head covering and to have gloves. Is it possible for you to implement?
Emergency.
Why are you laughing, man?
Like we can wear mask, glove. We can wear mask and glove and caps. Yeah.
What about
Eyeglasses?
you buy your own glasses? What is that? Correct, no? Those glasses, disposable glasses are useless. Some good quality glasses we can buy for ourselves for a long time. What do you say? Like that we can do. Okay? Sorry, I think we will pause here. Anybody has any questions, doubts, queries, feedback? Huh? See, penetrating injury is something is penetrating and damaging the tissue. Blunt injury only, we don't know what has happened inside. Penetrating, at least we know this went from here to there. And there is one tendency for people to do what? To take out the foreign body. And many a number of times taking out the foreign body will be dangerous. Why? Because as soon as you take out the blood vessel which was obliterated by the foreign body itself will cut into two and it will bleed and patient will die. But if we take the patient with foreign body, we may be able to do something with respect to radiological intervention or some kind of surgical intervention. For example, knife injury. Knife has gone and sat just on the internal carotid artery. Now if I remove, the internal carotid artery was actually blocked by the knife tip. Now as I remove, internal carotid artery will start bleeding. What should we do? Should we remove or should we let it be there and take him to the OT and there we remove? If we remove there, it is easy. We have already catheterized the patient, we have put BSA we have done, we have put the catheter and we know, so we can obliterate the ICA also down proximally. We obliterate the blood flow, we suture and then we release the blood again. What do you say? So all these things are there. That is the difference between blunt and the penetrating injury management. Blunt injury only, there are so many other things which can happen. For example, chest injury is there or blunt abdominal injury is there. At that time, there are so many other things which we need to take care of. If suppose muscles are injured in a blunt manner, so what is going to happen? Rhabdomyolysis. And what it can cause? Anybody has any idea? If muscles are pressed under the truck has gone over the muscles, truck has gone over the limbs, muscles are crushed, what it will cause? Rhabdomyolysis. That muscle, liquefied muscle has gone into the blood, rhabdomyolysis. Myoglobin is going to go into blood. Blood is going into the kidneys and that protein is going to block the kidneys and there will be acute renal failure. Patients actually die many a number of times. Not only that, they release lot of potassium. Muscles crushed will release lot of potassium and patient's heart may stop just like that. So these are all very interesting stuff. That is why you have to be potassium chelator so that potassium levels are normalized. That is why you have to read. If you see what injury is there and you know these are the things which are mentioned or this is your experience, what will happen? You will be able to do better things for the patient. Otherwise, you will just keep on chasing some investigations, doing something funny thing. Today patient is like this, tomorrow patient is going to be like that, day after tomorrow patient is going to be like that. All the natural history of the disease you have to read. What it is called? Natural history of the disease. Natural history of injury at least you read if you want to continue on this path. Okay? Anybody else? Anything else? For all of you, homework is every day stand in front of the mirror, take your children's books or your neighbor's English books and stand in front of the mirror, read for at least 15 minutes loudly and laugh at yourself. Okay? Serena, all the best. Thank you.